Hello everyone. So this is the third video on the topic insulin and oral anti-diabetic drug. So in the first two video I have covered this anti-diabetic drug. So you can see this anti-diabetic drug both oral as well as parenteral. I have covered all. So let's quickly revise all these by doing few of the multiple choice question. So first one is all of the following they are true about metformin except. So we're talking about the metformin. Metformin क्या है आपकी? It is a this one biguanide. So this metformin we are talking about this the drug which acts by overcoming the insulin resistance. So the first choice is causes little or no hypoglycemia in non-diabetic patient. Okay, so this one is a true. Act by increased insulin secretion. So that means is it insulin secretagogue? You can see here the drugs which act by enhancing the insulin secretion. They are sulfonylurea, meglitinide and DPP4. So this drug does not act by increasing the insulin secretion. So this is false. Then increases the peripheral utilization of the glucose and decreases the absorption of the glucose from the intestine. This is also how it is going to act. This is also true. When given with alcohol, it increases the risk of lactic acidosis. This is also true. So here the correct choice it is B. Now moving to the second MCQ. Which of the following does not cause hypoglycemia? Remember one thing, hypoglycemia that is most commonly seen with the insulin and the drug which act by causing the release of the insulin. Insulin secretagogue. So here insulin इससे होता है hypoglycemia. Glimepiride it act by causing the release of insulin. This is also going to cause a hypoglycemia. Metformin this is going to act by overcoming the insulin resistance. It is AMPK agonist. Then gliclazide this is also insulin secretagogue. So all they cause the hypoglycemia except this metformin. Then which of the following drug used to treat type 2 diabetes mellitus causes the weight loss? Again, the drug which act by causing the release of insulin, their side effect is weight gain. So sulfonylurea group of drug and meglitinide natiglenide. So this is a sulfonylurea meglitinide analog and this is also sulfonylurea. And their side effect is they cause weight gain. Whereas this one it causes a weight loss. Which of the following can cause lactic acidosis? So again the lactic acidosis that is the main side effect with the biguanide. Already I have told in my previous video when I discussed the biguanides what are all the things which can aggravate this lactic acidosis. It is most commonly seen under the biguanide. We have two drugs, fenformin and metformin. It is very commonly seen with the fenformin. Because of this side effect, this drug it is banned. But under few conditions even we see the lactic acidosis even with the metformin. Otherwise metformin the main side effect is it causes the folic acid deficiency. Folic acid and it causes the megaloblastic anemia because of the vitamin B12 deficiency. Now coming to the next one, a diabetic patient and hypertensive patient taking several drugs presented with septicemia. Serum creatinine levels they are 5.7 milligram per deciliter. Which of the following drug should be stopped? Renal problem is there, patient is having septicemia, infection है, diabetic भी है, hypertensive भी है, septicemia है, तो ठीक है, insulin we can give. Metoprolol, maybe because of the hypertension. Then linagliptin, this is a beta blocker. This is DPP4 inhibitor. And this is biguanides. So DPP4 inhibitor, this is also not to be given in patient with the renal disease except linagliptin. ये इसमें एक exception है. So even patient with the renal disease we can put a linagliptin. But metformin, of course, we should not be given if the person is having any renal complication, because it is going to aggravate which side effect? Lactic acidosis. So यहाँ पे what is the choice? It is a metformin. So you can see most of the majority of the question they are from the metformin. So this is a drug of choice in type 2 diabetes mellitus. So you will be getting many questions from the metformin. The next MCQ, all of the following statement about alpha glucosidase inhibitors, they are true except. So alpha glucosidase, like we are talking about acarbose, alpha glucosidase inhibitor, the drug under this comes acarbose, voglibose and miglitol. Now alpha glucosidase, this is the enzyme which is present in the intestinal brush border. It helps in the absorption of the carbohydrate. Polysaccharide ko monosaccharide mein it is going to convert. So it is going to increase the absorption. I am talking about the enzyme. But if we give the inhibitor, that means action will be opposite. So it is going to reduce the absorption of the carbohydrate. So first choice, it is true. Like it reduces the intestinal absorption of the carbohydrate. That is true. Effective in both type 1 and type 2 diabetes mellitus. Yes, it is going to decrease the hyperglycemia, especially the postprandial. Even the type 1 diabetes mellitus, though it is not approved for the type 1 diabetes mellitus. So this is also true. Hypoglycemia, that is common and serious adverse effect. It is a mild anti-hyperglycemic drug. So hypoglycemia, that is not common and it is not at all a serious adverse effect. So this is a false. We can use it with other older hypoglycemic agent. Yes, we can use it. So here, which one is a false statement? This one. Now coming to the next one, any patient if diagnosed with the diabetes, then how we go about that patient? If it is a type 1 diabetes mellitus, then we do a few dietary modification or lifestyle modification, and with the type 1 diabetes mellitus, insulin is to be given. So if it is controlled, okay, and other drug which is which has got the FDA approval, that is pramlintide. This is the one which we can use for both type 1 and type 2 diabetes mellitus. One of the important MCQ. Now, what about the type 2 diabetes mellitus? Type 2 diabetes mellitus, what is the current recommendation? Any patient diagnosed with the type 2 diabetes mellitus, along with the lifestyle modification like exercise and dietary modification, we have to prescribe the patient metformin. This is the drug of choice until and unless there is any contraindication, like patient is having any renal disease, hepatic disease, pulmonary disease, ठीक है, hypoxia है patient को with a shock, patient is hypotensive or patient is taking alcohol. If there is any contraindication, then only this drug it is not to be prescribed. Otherwise, this is the drug of choice. And if there is a person's, if it is controlled, it is okay. And if it is not controlled, this blue color, if it is uncontrolled, then what to do? If it is uncontrolled, then uncomplicated, this is the time when we have to add along with the metformin one more drug. And which drug? Sulfonylurea group of the drug, they are the second choice. And if a person is showing only postprandial hyperglycemia, we can put the patient on miglitide. Okay? If it is controlled, it is okay. And if it is not controlled, this is the time when we have to add the third drug. And usually the third drug, we prefer thiazolidine dione derivative, that is pioglitazone. So if it is controlled, then it is alright. If it is not controlled, then we have to put the patient on insulin. So insulin is to be given along with the metformin plus minus sulfonylurea or DPP4 or alpha glucosidase inhibitor. किसी के साथ भी we can add in type 2 diabetes mellitus, we give the insulin. And what are the other conditions when we have to put the patient on insulin in a type 2 diabetes mellitus? If the person is underweight. This, then if to tide over the, so सबसे पहले है when to give this insulin in the type 2 diabetes mellitus, if it is not controlled. If it is not controlled with the oral anti-diabetic drug, then we have to put the patient on insulin. This is number one. Number two, if the person is underweight. Number three, if there is any complication like diabetic ketoacidosis or any other complication with the diabetes mellitus, then also we have to, like diabetic ketoacidosis, that is the main complication with the type 1 diabetes mellitus, but here also if you see any complication, then we have to put the patient on insulin. Then during pregnancy, and to tide over the infection, trauma or any surgery, we have to put the patient on insulin. So these are few indication of the insulin in a type 2 diabetes mellitus patient. If it is uncontrolled, if the person is underweight, it tide over the infection, trauma and surgery, and during pregnancy. Now what all type of insulin we have? So we have the older preparation or a conventional preparation which we use to prepare it from the beef and pork pancreas. So what are the disadvantage with that beef and pork pancreas? They used to contain 1% other proteins, okay, which used to exert the antigenic property. And what are the other protein? We have proinsulin, okay, then pancreatic polypeptide, and various other proteins. So these are about 10,000 parts per million. They were this, and they exert the antigenic property. So because of that, this has been replaced. बनाई कहाँ से conventional? From the beef and pork pancreas. Beef and pork pancreas. So this is totally replaced by highly purified insulin preparation, human insulin and human insulin analog. It is conventional preparation, it is replaced by this. Now in highly purified insulin preparation, what we do the purification. Purification कैसे करते हैं? There are the technique. जैसे हमने इसकी purification कर दी with the gel filtration and ion exchange, chromatography. इससे क्या हुआ? That impurities or the protein part that is less than 10 parts per million of the proteins will be there, and we are going to get the with this single peak insulin and monocomponent insulin. Okay. Then another one is human insulin. Human insulin is by recombinant DNA technology. They are the more soluble, more defined peak, they are more stable, and no antigenic and no reaction they are seen with the human insulin. These are the advantages of human insulin over the other insulin. So they are formed by the, we get it by recombinant DNA technology. And with the recombinant DNA technology only, we are going to get this human insulin analog. So here what we do, we are going to modify certain pharmacokinetic parameter without any change in the pharmacodynamic, without any change in the efficacy. Now, what are other what all insulins we have with this purified technique, human insulin? So with this we have the most common, that is regular insulin. So what is a regular insulin? Regular insulin, it is at a neutral pH solution and there is no modification, unmodified insulin which we have made stable by adding a small amount of zinc. Okay. So with that small amount of the zinc, what happens? All the insulin molecules, they are around this forming a hexamers, a stable hexamers. So as soon as you give this by subcutaneous route, then what will happen? The monomers they are released, and this way it is going to exert the action. But these are released so slowly, and peak effect that is going to see 2 to 3 hours, and duration of action with this it is 6 to 9 hours. Okay. This is when we are giving this drug by subcutaneous route. Now what is the main disadvantage with this? The peak कब आ रही है हमारे पास 2 to 3 hours. So there is mismatch between the whenever it is required and the availability of the insulin. That means if you are using the regular insulin to the person has to take this insulin 1 hour before the meal. एक उसको वो लेना 1 hour before the meal. Second thing is that basal rate, it is not, because duration of action that is also less, so it is not going to cover that basal or the insulin requirement which we need in between the interdigestive period. So these are the two shortcomings with the regular insulin. But the same thing, if we, and so how we are going to modify this? So modification that is done with this insulin, so it is now modified. इसको modified कैसे करते हैं? We are doing the modification. So modification of this insulin, it is done with the by adding either a small amount of protamine, that is base, or we are adding a zinc particle. With the protamine, this is insulin is called neutral protamine hagedon. So pH is neutral. जैसे इसमें यहाँ पे था pH is neutral. Here also we are going to keep the pH neutral, and we are going to add a basic protein, that is protamine, and this is done by the person, this insulin hagedon. So that's why it is named with the name of this person, hagedon. And how much protamine is added? It is just sufficient so that all the insulin molecule, they make a complex. We should not get any free protamine molecule or any this thing insulin molecule. So this also, when you are going to inject subcutaneously, monomers will be released, but the that effect is not very much consistent with this protamine. So usually this neutral protamine hagedon, this is given with the, इसको किसके साथ देते हैं? We give it by the with the combination of regular insulin. So हम regular insulin and neutral protamine hagedon combination देते हैं. Either it is 30 to 70 or it is 50 to 50. ये दो combination. Then coming to the this one. So this is given in combination with the regular insulin and NPH. Now with the zinc. So zinc, either the large crystal they are added or a small crystal they are added. So large crystal, that is a crystalline. Then small particle, that is amorphous zinc, that is added. Now this is going to give the semi-lente preparation, and this is going to give the ultra lente preparation. So हमारे पास ये दो आएंगे, ultra lente and semi lente. So these two, they are not marketed. The combination of this is marketed. The combination of this one is called lente preparation. उसमें कितना? This is 70 and this is 30. So this combination, this is used. So but this regular, this is about when we give the regular insulin with the subcutaneous, what will happen? What are the shortcomings? We have to take meal 1 hour before, then it is not going to cover the interdigestive period. So we have got the modified insulin. But one advantage with the regular insulin is when we give it by IV route. If we are going to give it by IV route, then what will happen? The monomers, they are released immediately. Then there is no this peak effect 2 to 3 hour. It is, this period is not there. So peak effect that is seen. So with the IV route. So this is the insulin, regular insulin, the only insulin which we give by IV route, that is regular insulin. So during emergency, if there is any emergency, then which insulin is to be preferred? It is a regular insulin. Why regular insulin? Because this is the insulin which we can give by IV route. So from the regular insulin we have, हमें इसमें से हमने क्या क्या derive किया from the regular insulin? We have got the neutral protamine hagedon, we have got ultra lente, semi lente and lente. So how we are going to classify this insulin? एक हमारे पास regular insulin आ गई, then neutral protamine hagedon, ultra lente, semi lente and lente, the 5 type of insulin. So one is a regular insulin, then we have a neutral protamine, then we have a ultra lente, semi lente and lente. So from the regular insulin only we have derived all these. So they are even with the by the human insulin, we can prepare it by the recombinant technology, or we can do the purification with the purification technique. Then we have the insulin analog. So human insulin analog, what we have? Lispro, aspart, glulisin, glargine, detamir and D-gludac, this one. So they possesses the novel pharmacokinetic property, and there is no change in the pharmacodynamic, no change in the efficacy. Like we are going to change a certain sequence of the amino acid in all of these insulin so that to change its pharmacokinetic property. Let's see the first one. So all these, they are the human insulin analog. Lispro. So how we are going to get the Lispro? So this is the structure of the human insulin. So by reversing, this is this is a Lispro. This stands for the lysine and this is a proline. So you can see the B chain, this is the proline and this is the lysine. By reversing this proline, okay, by reversing this from the 28 position, हम कहाँ पे ले आए? 29 पे, and this is on the 29 position, we have got it 28. With this little change, what we have got, now the hexamers, they are going to form a weak hexamer. So as soon as you are giving a subcutaneous, what will happen? There will be release of this monomers, and that is going to make it a rapid acting insulin. So it is going to, we are going to get the quick and more defined peak, and it is giving a better control of postprandial hyperglycemia or a post-meal hyperglycemia. So this is the insulin Lispro. Now second one is the insulin aspart. Now what in insulin aspart? This proline here, instead of the proline we have added aspartic acid. Okay, so insulin aspart mein what we have done, insulin this one is changed. With that again the same thing we are going to get. So weak hexamer they are formed, and this is going to make it rapid acting. Then next one is insulin glulisin. So here this proline, sorry this proline, यहाँ पे हमारा क्या लग गया? proline की जगह we have added a glutamic acid. So with that again the same thing. So 3 insulin, Lispro, aspart and glulisin. So with all that change in the sequence of the amino acid, they are going to change its pharmacokinetics. So they are going to make it weak hexamer. So as soon as you are going to give it by subcutaneous route, what will happen? The immediately monomers they are released. That is going to make it short acting. Now coming to the another 3 that is these glargine, detamir and D-gludac. Now what are the changes? They are there in glargine. So in glargine there are addition of 2 arginine molecule in the B chain, and in the A chain the glycine, that is this is in the B chain, and in the A chain the glycine that is going to replace with the asparaginase. Now, what it is going to, with this change of the sequence in the amino acid, what will happen? This insulin, it is going to make it in a solution form only at pH 4. It is going to make it acidic. At the pH 4, this insulin, it is in a solution form. So when we are going to give this insulin, this I have taken it from the net. So you can see here the insulin, it is at pH 4 or acidic pH, it is present in a solution form. But as soon as you are going to inject, what happens? The clumps, you can see clumps or precipitation of the insulin, they are there, small crumbs you can see, and from here the insulin, it is released slowly. This is going to make it what? Now slowly it is released, this is going to make it a long acting insulin. So it is also called a peakless, a single dose injection at a bedtime, that is given with this, and it is going to take care of the basal requirement of the insulin throughout the day. And same is with the other determer and degludec. With the determer, what happens? The one fatty acid that is attached with that, with the attachment of fatty acid, what happens? If you are going to give this insulin, it is going to bind with this albumin molecule, and it gets attached with the albumin. And with this albumin, once it is attached, then from this insulin, it is released slowly. So this is going to make this insulin also a long acting. Same is with the insulin degludec. So that is also going to supply the insulin over a period of 40 hours. So these insulin, they are also called a peakless insulin. We give a single injection and they are going to take care of the basal control, basal requirement of the insulin. So this is about the insulin degludec. Okay. Now you can see in this figure what are the this different. This is human insulin analog. All these, they are the rapid acting insulin. So before that, okay, now if I want to classify, how we can classify? So classification, this is very important question of the insulin. Classify the various preparation of, or write the various preparation of the insulin. So how you are going to classify it? One is a rapid acting, then we have a short acting, then we have a intermediate acting, then we have a long acting and ultra long acting. So you can combine this to ultra long acting and a long acting. So what all we have with the rapid acting? With the rapid acting, we have insulin, Lispro, Aspart and glulisin. With the short acting, we have a regular insulin and a semi-lenti insulin preparation. With the intermediate, we have a neutral protamine hagedon or a lente insulin. And with the long acting, we have a ultra lente. And with the ultra long acting, we have a insulin, glargine, determer and degludec. ये हमारे पास तीन तरह के इंसुलिन, ग्लार्गिन, डेटिमर एंड degludec. These are the three type of. This is how we are going to classify the insulin. So in the next, you can see Aspart, Lispro and glulisin, how rapid they are and their duration of action. So within 15 to 20 minutes, the peak effect that is in less than 1 hour. Okay? and duration of action, it is a 4 hour. Regular insulin, this is a short acting with the duration of action 6 to 9 hours. Then neutral protamine hagedon, this is a intermediate acting insulin. So you can see this also. This is a time and this is a plasma concentration level. And detamar and glargine, they are the peakless insulin, and they are going to give a this one ultra long acting. So this is very commonly asked in the exam. Classification of the insulin, or write the various preparation of the insulin. So you have to write all these. Now coming to the newer insulin delivery devices, this is another important short note. What comes under this? We have insulin syringes, pen devices, inhaled insulin, and insulin pump, also called continuous subcutaneous insulin infusion devices. Insulin syringes, like earlier we had this thing vial, हमारे पास पहले ये vial होती थी. So we had this vial, and this is a insulin syringe. You can see we give insulin. What is the main route? It is given by subcutaneous route. Except the regular insulin, we can give regular insulin also by subcutaneous route, but we can give it also by IV route. So during emergency, which insulin is to be given? It is by regular insulin. One point I just forgot to explain with the glargine insulin. So this insulin, it is at the pH 4. This is at the pH 4. It is in a solution form. So this insulin, it should not be mixed with any other insulin. Okay? So insulin glargine should not be mixed, because we have to maintain it in a solution form, which is possible only at a pH 4. So insulin glargine should not be mixed with any other insulin. Okay? So insulin syringes, so nowadays pre-filled insulin syringes, they are there, so you don't have to carry this vial and all. Then portable, this pen-like devices, इसमें क्या आपके disposable, this cartridges where we can preset the amount of the insulin, how much you have to take it, कितने units लेने हैं, and we have a disposable needles. Cartridges and needles, they are disposable, so these are the portable pen injectors. Then next is the inhaled. We have two, Exubera and Afrezza. This is banned because of the pulmonary complication. This is the one which is used, but it is again, it is going to give the action only for 3 hours. So controls the mealtime hyperglycemia. We have to combine it with the other insulin or long acting like glargine. Then another one is a continuous subcutaneous insulin infusion devices. So this is just like a pager. एक छोटा सा device है, just like a pager. उसमें क्या है, like you can see here this chip like device, and it is along with the tubing, and this tubing, where it is on the abdomen. This is the one device like which is there is no need to carry anything. So this makes the person flexible. So what this pager like device, it consists of what? So I'll draw here this device. It is having here the insulin reservoir. Then here is a microchip. इसमें आपकी microchip होती है. So by which you can preset the amount of the insulin to be delivered at the post meal and for the basal rate. And then here is the catheter, and this catheter, it is connected with this, जो यहाँ पे white color का है. So what it is like this. It goes inside the skin, और ये आपका ऐसे ऊपर से you can see it like this. So this is going to deliver the insulin. So here the main disadvantage, it is a cost. You have to adhere with the diet. There should not be mismatch. Like if you have missed the meal and you have preset it, and then infection at the site. And then another thing is you have to change it also. You have to change all that. So these are the new insulin delivery devices. Now the next one is a mechanism of action. So usually the question is asked, classify or write the various preparation of insulin or classification of the insulin. Write its mechanism of action. ठीक है, therapeutic uses, adverse effect. ठीक है, so mechanism of action, this I have taken in the first video. So insulin, how it is going to act, it is going to bind with the insulin receptor which is present in almost all the tissue. And remember, insulin, it is going to act at 3 level. एक ये membrane level पे है आपका, then at the cytoplasmic level, and the third one is a nuclear level. Membrane level पे it increases the uptake of the glucose. Cytoplasmic level पे it is going to cause the activation and inhibition of the enzyme. Activation of the enzyme, which enzyme? Which is going to cause the utilization of the glucose. Uptake of the glucose, or inhibition of the enzyme, which is going to cause the production of the glucose. It is going to cause the inhibition. And at the genetic level, it is going to cause the transcription of the genes. Which kind of the genes? Which is going to cause the increased synthesis of the GLUT4, glucose T4. This is going to transport the insulin from the plasma towards the cell. So you can watch that video if you want to see in detail how insulin it acts. So what is the mechanism of action of the this insulin? So in the next video, I will be taking the therapeutic uses and the various adverse effect or reaction of the insulin, just revising so far with the different type of insulin, with a few of the multiple choice question. So first multiple choice question is, all of the following preparation, they are rapid and short acting except rapid and short acting lispro, aspart and glulisin. ये तीन मैंने बताया. Glargine, that is a peakless, it is a ultra long acting. The component of lente insulin. Lente insulin is the only one which is marketed. So it is a component. अब usually क्या हम बोलते हैं, ultra lente and semi lente. Semi lente आपका 30% है. This is a semi lente short acting, and this is a ultra lente. Remember, in a semi lente, the small particle, the zinc, that is size is small, and crystalline, this is zinc size, that is a bigger one. So this is the correct choice. इसको आपको you have to remember this one. Insulin causes all the following except. So insulin, it is a anabolic. तो ये क्या करेगी? It is going to cause a utilization of the glucose or deposition of the glucose. Glycogenesis. So glucose that is converted into glycogen. ये right. Then glucose that is used. Glycolysis, utilization of the glucose. This is also right. Lipogenesis, the deposition of fatty acid. Ketogenesis, it is going to cause the removal of this. It is a anabolic. So this is the choice. It does not cause the ketogenesis. Now next one is a long acting insulin. We have lente, semi-lente, ultra-lente and lispro. Lente intermediate. This is a short acting. This is a rapid acting. Correct choice is ultra-lente. Then the long acting insulin preparation, they are frequently administered by कोई भी insulin आए except the regular insulin. Rest of the insulin, the route, it is subcutaneous. सीधा subcutaneous route पे इसको आप लगाओ choice पे. Then next, the following insulin can be given intravenously. सीधा regular insulin. अभी मैंने बताया. Which insulin is never mixed with other insulin? It is a Glargine. इसको किस पे बनाया? pH 4. It remains solution only at the pH 4. Never ever mix insulin Glargine with any other insulin. So that's all for today's video. So I would like to know whether my video, they are useful to you or not. So if you find it useful, please press the like button and subscribe my channel.